Hopefully this will be an interactive session. For those of you who don't know me, I'm Dr. Andy Mitchell. I'm the Medical Director at the Regional Office. I do feel quite privileged, actually, to have been asked to take part in a session on primary care, because I'm certainly not a subject matter expert, although some of my colleagues have suggested I've learned so much about primary care over the last few years that I could be an honorary GP. Now, I'm very glad that Claire is taking part in the session today. I asked Claire if she would chair our London Transformation General Practice Primary Care Board, and I'm delighted that she's taken up that opportunity, because I'm sure her innovative thinking and her drive is really going to help us transform primary care services in London. What I would like to do, I think, is three things by way of kicking this session off. I want to give you my particular thoughts about call for action. As just a general overview, I want to give a few thoughts about transformation of the system, not just primary care, but the system overall, because we can't look at primary care in isolation, as I'm sure you'd agree. And I just want to reflect briefly on some of the leadership structures that we've put in place, which could, I suppose, help facilitate the kind of change that we need to make. Now, of course, we know all about the financial challenge. We know the scale of the gap. We know that we are going to have to undertake quite significant and radical change in healthcare provision in London. And that is going to mean a debate with the public, which this is all about, and also some quite radical decisions to be made. It's been a fascinating discussion this morning, but there's no doubt that we're going to have to rethink the way that we provide services, focus on preventive care. How do we promote healthier lifestyles in London? And I think the Mayor's Office has got a key role to play in that, and you may have heard of the Mayor's Commission, the Healthcare Commission, which will be kicking off in the very near future. So I think that link with the Mayor's Office and actually fulfilling that remit is crucially important. We are going to have to think about much more personalised care, and there was discussion about the home being the focus of that personalised care, which is actually a very interesting and cogent thought to take home. We are going to need to think about promoting primary care, because this imbalance, of course, between hospital and provision of primary care services does have to be addressed. There will have to be money that comes out of secondary care services, and I think Claire's question earlier on about how we're going to achieve that, of course, is a crucial one. We do need to have to think in terms of integration, and we do as well need to have to think in terms of transformation of hospital services. And these are going to be very difficult arguments to get across to the public. I actually look at, in terms of moving on to the idea of system transformation, look at it in actually a very simplistic way. There is transforming primary care, which this session is going to be about. There is the transformation of secondary care services, and of course we have to achieve integration between the two. Let me just dwell, if I can, on transforming secondary care services. Much of this has, the way hospital services have currently function has to change, and I think the Royal College of Physicians document on the Future Hospital Commission is actually a very good model that we need to pursue. We've talked a lot about standards, and I think the real difficult thing that we're going to have to face is actually how we can actually incorporate the agreed standards, those that have been agreed by the Senate, into practice. Because it is quite difficult, actually, in terms of just saying they will be introduced into commissioning intentions and contracts, because there has to be quite significant behaviour change, and we have to encourage very different behaviours. There is quite a lot that can be done without any significant change to the consultant's contract, I believe. And if listening to organisations and trusts that actually have taken on board the message of 7-7 services, because that's what we're talking about, they are already beginning to see benefits in terms of reducing that Monday morning effect and improving productivity and improving flow. And if the first thing that we could achieve would be greater weekend presence within the confines of the contract, I think that would be a major step forward. But I do believe that we have to move towards a standard-based commissioning approach. So that's my view on secondary care. In terms of, but the key thing is, how do we promote the integration agenda? And of course, integration means different things to different people. We talk mostly, of course, absolutely crucial, integrating services with social care. But there is something crucial to my mind, and I think this is important in the future of primary care services. How do we break down this very artificial barrier between primary and secondary care? Because it is a completely artificial construct, it's not one that the patients actually recognise or understand. And I think Michelle was reflecting back to her time, thinking about how things used to be 30 years ago. When I started as a consultant 25 years ago, I knew every GP on the patch. We used to have regular conversations. If there was a discussion about a case, it would be a matter of pick up a phone. And actually, I think we can achieve integration by simple reversion to sensible behaviours around communication. It is not rocket science. This can be done for free, but there is something about encouraging different behaviours, different kinds of contacts, which for over the years have been lost. Because I do believe that we need to focus on as much on integration with secondary care services as with primary care. So, and we need to find the levers to do that. But it is about leadership and promoting behavioural change and role modelling. So that's just a view on how we move about transforming the system. I just want to talk briefly about the Clinical Senate and the networks and what role they may play. There was an article written in one of the commissioning journals last week, and it was written by a GP in East Anglia, and he hadn't been a great mover and shaker in his time as a general practitioner practicing in East Anglia, but he was voted on to the Clinical Senate Council, and he said what an honour it was. And he actually gave a very telling line, because there's a lot of confusion about what Senates are about. He said, "Delighted to belong to the Senate. I view this as the conscience of the NHS." And that's, to my mind, that encapsulates what the Clinical Senate is about. Anne mentioned earlier on the process of leadership engagement that we've gone through. We now have approximately 1,000 clinicians who are signed up and are virtual members of the Clinical Senate. They're not a statutory body, they have no decision-making powers or authorities, but they are there as a sound body of advice, and I think we need to build upon that. Similarly, the networks. We have 20 networks which are looking at strategic development and actually beginning to change the way that relationships and collaboration works. I think it's crucial that whatever change we go through, we build upon those mechanisms that are there. Now, I suppose I want to pass over to Claire at this point, but the one question that she posed to me earlier on is, how do we create collective leadership structures for primary care across London in the same way? Because the Senate has had a secondary care focus. And I think there is a real issue about how we can, knowing all the slightly disparate leadership systems that there are in general practice, can we create a cohesive approach so that we can drive transformation through? Now I'm going to hand over to Claire, because she's got a few words to say, I hope, about primary care. I'm sure you have, Claire.
No. Yes. Okay, I'm not going to talk for very long because I think we need to pull on your brains. But what I am going to say is hopefully resonates with the discussions. There has been 3 very important publications that have been published in the last few months. The first, as Andy said, is the RCP Future Hospital Commission, which is a very important document. The second, and I would say this, is the RCGP 2022 Vision for General Practice. And the third is the LMC's document that was published only a couple of weeks ago. Now, I say that because what we mustn't do is reinvent wheels. Now, we can change what those documents say slightly, and we can add things, because clearly no document is ever 100%. But I think if we're going to move on and transform general practice, primary care, and London's NHS, then we have to build on what I imagine has taken, certainly the RCP Hospital Commission was 18 months. My document was 2 years, and I don't know how long Michelle's was about 30 years. But you understand what I mean. Now, the document that I know best, which is my own document, talks about 2 things that have to happen. One of those things around general practice is it has to stay the same. And the other one is that it has to change. And how do we marry that up? The staying the same, it is fundamental that we build on what works in the NHS, and that we build on the first point of contact, there are many first points of contact, but the GP is the main first point of contact for undifferentiated illness, for those people who think themselves to be ill, based in a community setting, with GPs acting as the risk sink for the NHS, as well as doing all the other bits and pieces, the advocacy, the gatekeeper, etc., etc. There is so much evidence for that. Unfortunately, we produced a compendium of evidence, so if any of you don't believe me, we have a 100-page document that shows you the evidence for that. So let's not reinvent the wheel. General practice works. Might be going through a few problems at the moment, but it certainly, when it works well, it works. But the second thing is we have to change. And the things that we put down around the ways we have to change, again, will resonate with you. GPs have to become more expert generalists. They have to become more physicianly, if that makes sense. We have to be doing case management. We have to be doing care of complex patients. We have to be doing all the things that you're talking about around risk stratifying our patients and providing the patients that we know are at greatest risk with enhanced primary care. Our teams need to be different. We need to be working much more, what I call as micro teams, teams within teams, restoring continuity of care, reducing fragmentation. Sam, your little man over there, what he wanted was continuity. It didn't matter whether he rang the nurse, rang this, he wanted the same person delivering his care. And we can only do that in the modern world, not by having that poor nurse on 24 hours, 7 days a week, 365 days a year, because she'll burn out, but by working teams within teams, sharing the responsibility with a small group of people. We have to be delivering better out-of-hours care, and we have to deliver different solutions for that. GPs also have to work differently at delivering how they deliver care. So, for example, we should be embracing e-health. We should be offering patients, and I know that my profession, and maybe Michelle would disagree with this, should be able to offer them the option of email, text, whatever, telephone, different sorts of modalities. This is the modern world, and we need to make sure that that works. And we need to be working, as we call, differently with our secondary care colleagues. And as Andy said, and I think that you heard earlier today, about breaking down this boundary that has actually been there since 1948. That actually was set up as an accident, really, marked by the hospital front door, which is primary care in one place and secondary care in the other place. Integration has 49 different meanings, and some of them you need a degree in Greek to understand. But basically, it means shared care that goes beyond the simple exchange of letters, that requires professionals to work across professional boundaries, but retaining their professional autonomy, ideally with a shared electronic record held by the GP, and ideally with a pooled budget. But let's keep it simple. But in order to deliver integrated care, we need to be developing, I would say, GP-led multidisciplinary teams, as we have in northwest London, but we need to be doing that fairly rapidly, not just around disease-specific, but around patients. So we've talked about the frail elderly. So to move on and to move from where we are now to where we want to get will require not just leadership, because there is plenty of leadership. In fact, some might say there is too much leadership in general practice, that's the problem with my profession, is that we have 64,000 leaders and they're called individual GPs. But we need to somehow get a collectiveness across London, working with secondary care in order to try and deliver what we now know we need to deliver, and fairly rapidly, which is integrated care, etc., etc., etc. But it's not going to be easy because GPs are very individual. And practices have grown up in places that historically might have served their need, but going forward may well not. And I know that Lord Darcy is re-looking at some of the issues around premises. And finally, we need to invest in education and training. And I know there's somebody here from the Letbys, but if we're going to get the NHS of the future, we can't just add on education and training as a last thought, or research and development, or premises development. All of those have to be integral with our vision going forward. So Andy and I don't have all the answers. We have ideas, we have thoughts, we have discussions that we've had, but we very, very much want to rely on yourselves and to get what you're doing in your area and what you think in order to reach a space, and we may have to discuss whether we all agree with the space that we want to reach, what your top tips are for going forward. Now, I just wondered, and we were thinking about this, whether you want to talk within your own tables first for about 5 minutes just to warm up, and then we'll have a general discussion. But I just wonder if there's any questions you want to ask at the first port. Can you say who you are?
Hi, I'm Shard Ahmed. I'm the Director of Public Health at Enfield. I suppose one of the things I just wanted to capture before we go into our discussion is the issue of health inequalities, because it was great to have the presentations earlier where we heard about the national picture and the international evidence base, But there was very little about what makes London unique and different. And to me, a lot of that is about health inequalities and the diversity of our population and the fact that we have so many small populations within our city and how we actually work with them. So that the health inequalities theme, I think, is crucial to our conversation about general practice. And what I'd like just to remind people of is, like, say, the work that the National Support Team for Health Inequalities did, led by Chris Bentley, and the excellent guidance they produced, that has massively narrowed health inequalities in many of the spearhead boroughs in London. And I want to make sure that we don't lose that and we continue to keep building on that. And I suppose my slight disappointment is that nobody's talking about that at the moment.
I think possibly people are, because the three greatest problems of the NHS at the moment that we have to address are fragmentation, continuity and widening health inequalities, except in the spearhead areas. Michelle?
Just three quick things, Claire. First of all, don't fall into the trap of thinking I'm like the BMA. I'm not.
Oh, right, okay. Never.
Having delivered the GP outcome standards and My Health London, accepted by all GPs in London, I'm very, very open to information sharing. How effectively it can be done, that's another thing. So let's just correct that one before we start. I think we need to talk about integration across what, if we're not careful, we'll get our knickers in a twist. General practice, extended primary care, multidisciplinary teams between all of those and social care, I think will give us the biggest bucks, the biggest hit for our bucks, and will actually be easier to achieve in short order under a transformational change agenda than trying to integrate systems across primary and secondary. We might need another 10, 15 years to do that to our satisfaction. Agree with Andy about communication and visibility being really important in the patient journey. Actually, I've done them. That's the three, so thank you very much. Oh, and the document, that was it. Happy to share.
And it's a very good document and starts to say. So Michelle's points, I think, were well made, absolutely well made. And what she said was the LMC is not the BMA. And so the LMC fully support the use of e-health, telecare, text, email, remote consultations, fully support delivering out-of-hours care in an integrated way with other providers. Good.
So I think that we all agree that there does need to be change in general practice, but I know in my local area our general practitioners are under a lot of pressure and they feel it, and they need to be convinced that actually they can change. It's not about wanting to change, it's about being able to change. I think the 9 national pilots will help us, but my concern is around the speed, because actually it's going to take time to actually set these up, to actually get the evidence, to be able to convince general practice that there is a way through this in order to support them, in order to make that change.
And if I can be so bold, I think general practice delivered many of the things that were up on that slide earlier. And it delivered them 15 years ago. But what's happened over the last 15 years is bits have been chopped off and removed and put into other places. And I think your point is absolutely well made. I don't know, how many GPs in this audience? And it's safe to say the GPs at the moment, I know that everybody in the NHS is struggling, but I think GPs are particularly struggling. I think that 6.7% for 90% activity is becoming unsustainable, and which means what's happening is that GPs can't put their heads above the parapet and actually start to innovate, because I think GPs can find the solutions and will be excited about working together, working across primary and secondary care, inviting our secondary care practitioners into the surgery to form MDTs, but at the moment are a little bit like that beaten dog. They're just going from one day to another without being able to lift their heads up. Now, the choice is yours. Either you get together in tables or we continue the discussion as a plenary. Hands up who wants to get together in tables. Hands up who wants to deliver as a plenary. Hands up who's abstaining.
I think we carry on with the plenary, don't we?
Andy.
Well, I suppose a question I'd like to ask actually is what, to anybody who's open to answering this, what are the key things that we need to do in the next phase of this, bearing in mind we've got the primary care call for change, a case for change coming as soon as well. What are the actions that we need to take in order to incentivise GPs to change, as we heard? What is it that's going to make the difference? And I think that's where we're looking to you for support in taking this forward. can I pose that as a question in the first instance?
Lady over here. Are there two roving mics or just one?
There are, but there's only one person.
All right. Somebody's stolen one over there. This lady here and you over there. Ah. Do you want to give it to this lady here who had her hand up? Yes. And then when you got yours to work.
My name's Cheryl Coppell from Havering Council, and I don't think I'm going to answer your point about specific GP incentives, but system incentives. I do think some of us are doing an awful lot of work to try and integrate the rest of the system down at a local level, and I don't mean just a single authority, but within a health economy. And the one big missing piece is GPs, and because of the way it's organised, we don't have NHSE there at the table. So, I'm going back to a 6 o'clock meeting of the Integrated Care Coalition in outer North East London. There isn't anyone there, and yet decisions that are being taken vitally affect that. And I think that has got to be put right, because certainly some research I've seen that's going on across London has demonstrated that there are huge cultural issues as well that are probably best addressed at a local level between what GPs think of social workers and what social workers think of GPs. And I think it's still true that GPs are the person who's are likely to be most listened to by an elder person when they're trying to decide what their future care should be. So I would like to suggest there's a very large amount of cultural work that needs to be done and would best be done on a patch as well as incentivising the system.
So it's engaging, systematic engagement and involvement of GPs in any multidisciplinary setting, which is a barrier to change at the moment. So we need to... Are the answers to that financial? Do we actually pay for the time? I think there's no other route in there, is there?
Can we just ask, this lady here who's saying, why are there no GPs at that meeting?
Well, there are GPs. There's a CCG. Sorry, the CCG are present,
Michelle,
but not anyone who's commissioning the GPs. And so, for example, I heard, although I chair the commission, I only heard as a very second party that decisions have been made to institute a GP surge in our area, which was to address some of the issues that I would otherwise have understood. Now, I'm not saying that's right or wrong. It might not be where I started. I might have started, if there was money in the system, by doing some of the things that I've heard you talk about, which is actually incentivise some very hard-pressed GPs to concentrate more on their most problematic patients and work in a systematic way. So I just think there's a disconnect between NHSE because it's being run at a London-wide level and the local integration effort that's going on within local health authorities.
I think that's a very important point, which I think I've certainly captured. It's what happens is the resources get put at the top and never get the folk down at the bottom to sort of do the work that needs to be done.
Kat Valley from Triborough Adult Social Care. Sort of connected to that and connected also back to what were the barriers to integrated working that we discussed earlier. I do think that where we have got integrated or multidisciplinary teams, one of the problems that I'm certainly aware of is in a way what you described as the GP-led multidisciplinary team. The lack of an equal respect for different professions, different contributions to the team, that if the GP's there, they're the leader, they're the one, it's the medical model, and everybody else has to follow on from that. Now, that may sound unpalatable, but certainly a perception in terms of both social care and, I think, community nursing to some extent, is that the GP-led team implies a lack of equality and joint working around all of the professionals working around the individual, which I think is something that, and as I say, the conflict between the medical model, social model approach to delivering that is something that we need to be aware of as we go through with the discussion.
And again, I think it's an important point. I don't say this because I'm protectionist around GPs, but I think the buck has to stop with somebody. And the problem about MDTs is you can distribute responsibility. So it's not that I think the GP is the best person. Actually, I do, because they're generalists. I think because as a generalist, they can cover all bases, but it's just that the buck has to stop. So it's not a sort of, we're better or worse. Michelle?
Well, I think let's translate this this to patients.
I don't think your machine's on.
It is.
Yes.
Let's translate this to patients. And actually, for whatever we mean, whoever's leading the team notionally, actually it is all about the patients that we're trying to help. So I think that's the way to strip out this kind of tribal discussion that none of us really want to have. And I'm the first person to say, actually, in any team, the leader will evolve, and it could be from anywhere. I think what we really need to do to answer the question, how can you incentivise GPs, but I guess we mean the whole of the primary care in its broadest sense system. Actually, we're already starting to do it. I'm really impressed this week with the amount of language that's being spoken about the sorts of things that GPs and others in social services and community services understand, which is home, whole patient, patient-centred, general, not in hospital, which is why I kind of get a little bit irritated when we focus on integration between secondary and primary. Yes, of course, that's got to happen, but actually we need to broaden it out. And creating facts on the ground and enabling those at the front line to do what they do best instead of being inhibited by systems, targets, organisational change. Just let them show how good they are and reward them for doing that, declutter the consultations, and actually we'll start to make a big inroad very quickly.
Can I just pick up on a point, actually, because this issue of generalism has been raised several times, and I'm treading on thin ice here, or sticking my head above the parapet, because there are some GPs here. Colleagues in hospital practice actually would have little confidence, to be honest, that GPs are sufficiently skilled at present to take on that broad generalist role. So there is a matter of confidence here, isn't there, and belief. Now, that's a challenge to Claire. She's just
they just need to provide the evidence for that, because I think a lot of people say things when there is no the evidence shows that GPs aren't the only generalists. Actually, I mean, there are other generalists in the health service, but I think the only person that can take a holistic, total view of the patient, that are actually trained to take a holistic view, psychological, social, physical, spiritual, is the GP. That's how we're trained.
But there is a gap.
There was always gaps.
So,
Nigel.
I mean, I think about Hilary Cass and Ingrid Wolf's evidence on our outcomes on paediatrics. Looking at some work I've been doing recently on primary care management in dermatology, in diabetes, there are some skills gaps which need to be filled.
Absolutely.
Yeah? So the answer to your question, I suppose, is a push and a pull, isn't it? We're not use the regulatory arrangements that we've got to deal with the people who are at the tail of the distribution.
No.
So we could do that. But I think sort of if we look internationally, the sorts of things you'd expect to see is probably more transfer of what we currently call the commissioning budget to larger practices of primary care. And you say you only qualify to hold this capitation budget if you're at a size which allows you to manage the insurance risk that's associated with that, which also incidentally gives you enough of a scale to have a PA of a couple of PAs of a geriatrician and a PA of a diabetologist and a respiratory physician, and start filling some of those skills gaps that we know exist.
And I think that's essential.
So, but what it does mean is you have to kind of blur the commissioner-provider split, which has become a bit of a dogma. But actually, I think in this particular case, it would be quite possible to construct partial capitation budgets. As practices get bigger, they can take on a wider component. And you start with community services. And I do think that the comment earlier illustrates something I come across a lot, which is lots and lots of integration projects not making much progress because they don't include primary care, which is kind of slightly bizarre. I think you have to start with primary care and then hang these other services around them. I mean, one other comment about the medical model, and what a disappointing thing to hear that still being said. I think Michelle said it. Leadership in these multidisciplinary teams ought to be a shared leadership model in which the most appropriate person takes the leadership role. And frankly, I hear the medical model, biomedical, social model thing from the managers in systems. I don't hear it from the practitioners, and I do think it's a very unhelpful thing.
From the what? Sorry, managers.
I hear it from the people at the top. I don't hear it from the people on the ground who are actually doing the work. And I think it's a bit disappointing that we keep coming back to that. We need much more situational and shared leadership models of arrangements. But a structured contract designed locally, and that means, I think the answer is, the last thing we need is a one-size-fits-all national GMS contract
absolutely.
anymore.
And I think, gentlemen, it's not that I think GPs can do it all, by the way. I think, of course, they need elderly care, etc. It's just that...
Shall we go Adrian, Howard and Mo? Adrian?
Thanks, Andy. In a way, it's following on a bit from what Nigel says. And I suppose it's a question about how are we setting about transforming primary care? Are we envisaging in some way that there is a vision of shared care for patients integrated around them, and that somehow various practices will find their own routes towards delivering that, one model? Or do we have in our minds some sort of structured model that we think works best, larger practices from Nigel, and that is the place to go? In which case, is there a drive towards imposing that model? So it seems to me quite fundamental to me that we start deciding how we're going to effect that change. And if it is the former, then we will find, I'm sure we will find, sufficiently good examples of where that's already happening, and whether that's Greenwich or Tower Hamlets or a number of other places, in which we should start highlighting role models of what it is we're trying to achieve, and really promoting that in a way that others can then start to emulate. Or do we think that there is a strategy in which a hub of combined care is the answer and has to be an element in every system, in which case we need to think through very quickly and make very clear what practical things, like how do you fund the capital for that? How do you release the capital out of single-handed practices without destroying the pensions of those people that own it, and put it back into a hub? So I think there are some fundamental questions about the how we're going to get to this, because we all know what the vision is in terms of the cartoons. That's all fairly simple stuff. It's the route of travel. Is it an imposed model? Is it 1,000 flowers blooming? If the latter, let's start getting some role models out there, which we know we'll find. But I think we need to clarify those questions.
And that is something that I think this audience needs to start answering, because you're the experts. Because there's lots of documents, there's lots of, the Nuffield Trust published not that long ago, fantastic document with the King's Fund on different models of primary care, fantastic options. We know the Royal College of GPs has had a federation policy for the last decade. It takes 2 years to set up a federation, and it costs a lot of money. Right.
I think we've only got time for a couple more questions, sadly. So sorry about
Shall we
this,
hear
but
from Mark and then
Mark and
the lady with the mic? You can stay, by the way, for the next
Annabelle.
session if you want.
Shall I just start? So I'm Annabelle Byrne from Greenwich, and actually there's a parallel session about the integrated model in Greenwich, and I just felt that I wanted to say a few things. Andy posed the question, what can help you to move forward with the integration? And I think one of the difficulties we get is trying to do the definition and trying to decide which bit of integration you want to go for. My advice would be to start. So it is about community and hospital services coming together, and that's what we're calling them now, not primary or secondary or specialist and generalist, because actually it's where people are treated that has caused the barrier, and it's about information flowing across that boundary, and the expertise actually being able to flow across the boundary. And then the work of getting local authority and NHS working together. And if we wait until we have an information system that works entirely, then again, you're a couple of years away, when you can actually start doing it immediately and absolutely wrapping services around general practice. But you probably can't do all of that at one time. And actually, if we learned from what everyone has done, we could start piecing together a really fantastic integrated system within the world we've got. If someone wants to come and change the contract, if someone wants to change the organisational form, then we have to live with it. But let's not wait for it or say that that's what needs to happen. We've got a workforce who are really committed to good quality care. Let's get them talking to each other and working together.
I think that's excellent, which is Mark, and then I think we're apparently wrapping up. Oh, sorry. The mic's gone. Who wants the last question? Democracy. You can stay if you want, Mark, for the next session.
Hi, my name is Steve Govan. I work in CCG in Newham. I think I just wanted to make a plea that in response to this question about how do you go about developing the new kinds of primary care organisations for the future. And that's that we do need to do a bit of learning from what's happened in the past. We know what happened around the poly systems, for example. I think it's really important that we do enable primary care organisations as providers to find their own way forward, but it has to be within a strategic framework that we all agree. And I think we should spend our time trying to agree a strategic framework for London for primary care. There's a lot of it that's already easily definable. That we could say around trying to grapple with those tensions around things like geography versus practices who can work together and trust each other, and some of those kind of tensions that need to be teased out. But a strategic framework for London within which primary care providers can then design their own solutions, I think has got to be the way that we go about it. I think if we don't put a strategic framework in, it won't happen, and if we do a blueprint, it will be imposed and it won't work. Because we do need to remember too as well what patients tell us about primary care. Some of the things they do like about the patient experience side is actually knowing the individual GP. One of the big issues on access is I can't get to see my GP. I can get to see any GP in the practice, but that's not what I want. I want to see mine. And that's a common theme that I get when I go out and speak to the public about what they're looking for from their practice. So I think it's really important that we have an ability to design a local solution, but within a framework we agree for London, we'll really foster it.
I think that's a very, very valuable point, actually. Thank you very much for that. We'll take that message home.
Thank you. I think we've been told by Nigel that we need to wrap up.